தெரியுதா சார்?
தெரியுது சார், தெரியுது. ஃபுல் ஸ்கிரீனே வருது.
ஓகே சார், ஓகே ஓகே. சொல்லுங்க சார், ஸ்டார்ட் பண்ணிக்கலாம் எப்பனாலும்.
ஆமா சார், கொஞ்சம் பேர் வரட்டும் சார், கொஞ்சம் பேர் தான் வந்திருக்காங்க.
சரி சரிங்க சார்.
ஓபன் சார், எல்லாரும் வர சொல்லுங்க. சார் நம்ம ஸ்டார்ட் பண்ணிடலாம்னு நினைக்கிறேன் சார்.
ஒரு நிமிஷம் சார். ஓகே
ஓகே சார். சார், good afternoon everybody. On behalf of the SRM family, I welcome you all to this third of the 9th lecture. And this lecture got postponed from Friday to today because of sir being somewhat busy in the meeting. So I am not wasting time. Straight away we go to the lecture. I request our speaker, Dr. Rajesh, to start his lecture. Thank you.
Good morning, everybody. I think I am visible now. The slides are visible.
Yes, sir. Yes, sir.
Okay. So we'll start. Today's topic is the various activation procedures. One second. So today's topic is the various activation procedures. So what is an activation procedure? So our aim of doing EEG is to see whether there are any abnormalities in the EEG. So we should be doing something to maximally create a situation where we get the abnormalities. So for that we have to do some procedures which are known as activation procedures. So today we'll go through an introduction to the activation procedures, an overview of what are all the various activation procedures, and just discuss a few routine lab activation procedures. So any procedure which is designed to enhance or elicit an abnormal EEG activity, especially the epileptiform abnormalities. So you do something to get the abnormalities in the EEG or epileptiform abnormalities. So simply you are doing an EEG, you may not get the abnormality. So we have to do these procedures to get the abnormality. So then that is why they are called as the activation procedure. So you are activating the occurrence of epileptiform abnormalities. They are known as activation procedures. So the activation procedures can be simple physiological ones like hyperventilation, or it can be something like the sleep, either occurrence of sleep or making the patient sleep, because in the video EEG definitely the patient will go to the normal sleep, so we'll get various activation of various abnormalities during the normal sleep also. Or in the routine EEGs, if you ask the patient to come after an overnight sleep deprivation, that is also a kind of activation. Then eye closure is also very important. It is one of the activation procedures. So we should know the difference between eye closure and eye closed phenomenon. Eye closure is similar to the photosensitive procedure. Eye closure is scotosensitive. That I'll talk about them later. So hyperventilation, sleep. கேக்குதா?
சார் கேக்குது சார், நல்லா கேக்குது.
So sleep, occurrence of sleep as well as sleep deprivation, both are activation procedures as well as eye closure. Now some stimuli. Other people can switch off the audio. I think it's interference. The stimuli can be visual stimuli like photic stimulation and auditory stimuli sometimes. For example, some children can have exaggerated startle response to sound or seizures which are stimulated by sound. So we'll give unexpected sound in the video EEG to elicit the EEG abnormalities. Some patients can have somatosensory reflex epilepsy. That is, they'll have some parietal scar, and when the moment their leg, the contralateral leg touches some object, they'll have a seizure. So that is one stimuli of the leg touching something or the hand touching something. That's a somatosensory stimulus. Then some patients can have olfactory, gustatory, behavioral, and vegetative stimuli. All can be part of activation procedures. Then the most important thing is the anti-epileptic drug withdrawal is one of the activation procedure for us to get the abnormalities. In this regard, I would like to tell you that two drugs, mainly the sodium valproate and levetiracetam, they are well known to suppress the occurrence of IEDs, intractile epileptiform discharges, especially in generalized epilepsy syndromes. The other drugs are not known to suppress the epileptiform discharges. And there are some drugs which can cause seizures. For example, the quinolones can sometimes induce seizures, and hypoglycemia can induce seizures in some patients. And other thing is special stimuli. As per the some of the patients can have seizures only while reading. It's called reading epilepsy. Only while writing, only while doing some calculation, and also the reflex epilepsy associated with eating. So that could be some of the activation procedures. The abnormalities in the EEG will come only when they eat or only when they read. So we should try to get the history from the patient as to when the patient gets these abnormalities, and these stimuli can all become activation procedures. So I discussed at length the various activation procedures, which can be regularly the hyperventilation, the photic stimulation. Then you can also have sleep or sleep deprivation, as well as the various other stimuli which I mentioned based on the individual case. So in a regular EEG, it's better that we include most of the activation procedures, which would include a hyperventilation, which would include a photic stimulation, which would include a sleep, and which also might include a sleep deprivation if you ask the patient to come with sleep deprived the previous night. So these are all the normal activation procedures which are included in the routine EEG also. Now going on to the activation procedure called hyperventilation. So Hans Berger was the first to describe the effect of hyperventilation on the human EEG, and it was very useful in absence seizure, and also in some of the psychogenic non-epileptic events, where when we tell the patient that the events can occur on hyperventilation, the susceptibility, because the susceptibility, hyperventilation is something which will induce the psychogenic event. So hyperventilation is useful not only in eliciting absence but also in psychogenic events. So what is the mechanism? The mechanism is cerebral vasoconstriction because of the carbon dioxide washout, hypocapnia. And cerebral hypoperfusion occurs because of the hypocapnia. There is vasoconstriction, and because of the vasoconstriction there is hypoperfusion. And also there is associated respiratory alkalosis, which will increase the neuronal excitability. And the hypocapnia will kind of enhance the synchronous activity of the thalamocortical projections. As you know, the thalamocortical projections are the ones which are responsible for the spikes, the 3 Hz spike and wave in absence. So the hypocapnia will enhance the thalamocortical projections, and also it will decrease the reticular formation activity. So basically it is hypocapnia which will lead on to the vasoconstriction, which will in turn lead on to hypoperfusion. And in addition, there is the presence of respiratory alkalosis and the enhanced activity of thalamocortical projections and decreased activity of the reticular formation. So the cerebral hypocapnia is directly responsible for the typical EEG changes, and there is also the direct effect of the hypocapnia on the brainstem. So if you're asked to point out the most important change which brings on the EEG abnormality, it is hypocapnia. So you instruct the patient to breathe deeply and rapidly with the mouth open for 3 minutes. Patients are usually lying flat during routine EEG. So, but if you are doing the test with the patient in an upright posture, you will get a better response. Because the patient will be able to do deep hyperventilation in the sitting posture than the lying posture. So, deep and regular respiration at 20 per minute for 2 to 4 minutes. It's not like like that, not like that. It will be 20 per minute, like. So it will be only 20 per minute for around 3 minutes. And to keep the eyes closed and the mouth open. So the patient, in addition, should be tapping continuously with his hand, or we can count the breath. So at least 1 minute before starting the hyperventilation, the EEG should be there, and the EEG is continued for at least 3 minutes after the hyperventilation ends. So the post hyperventilation changes are also important in many diseases, the post HV alterations. If you see some repetitive discharges or seizures, then you can stop the hyperventilation. So what is the normal response is that you get slowing of the alpha and beta rhythms, then a gradual slowing of the background, theta will come in, followed by delta. Then there is a fluctuating increase in synchronous slow wave activity, and this will be most marked in children. So if you see, as I told you the previous day, the posterior sharp waves of youth will tell us that the age is between 15 and 20. Similarly, when you see a marked HV response of generalized or bilateral delta waves is a marked response, then you can say that it is mostly children who tend to have like 8 years old, 9 years old. They tend to have very marked abnormalities, not abnormalities, now very marked response to hyperventilation than the relatively elder population. So commonly the posterior areas are maximum affected, but it can also be seen anteriorly. In younger age group, it can be seen anteriorly. It will tend to appear in the frontal region and spread posteriorly in the older age. And the slowing due to HV usually disappears in, that is the most important thing. So if it is due to HV, once we stop the HV, the changes will disappear in 1 minute. So that is very important, that the post HV, why we are doing it is, number one, you want to see whether the occurrence of the slow waves has stopped in 1 minute, number one. Number two, whether there is any new onset slowing after the HV has ended. That is a very important abnormality which you look for in the Moya disease. So I will come to that later. So in younger age group, as I mentioned, the delta waves are seen in the occipital regions with the anterior spread, whereas in the older age group, it is more anterior origin with posterior spread of these slow wave activities in the EEG. So this is one of the EEGs, a 10-year-old patient, male patient showing EEG, showing a beautiful background alpha, which you can all see. So you can see the HV start, which is mentioned there. And you can see that the HV is going on to 10 seconds. So nothing remarkable seen. Now it is going to the 20 seconds. Now it is 1 minute and 30 seconds. Now we can see the burst of the slow wave activities which are seen diffuse more in the frontal region. It's actually seen generalized slow wave discharges which are seen here, and these are all the post HV. During HV you can see this diffuse delta activity, which is a normal phenomenon. Now as it reaches 1 hour 40 minutes, you can see more and more extensive response. A 10-year-old boy, you can see more and more extensive response. You can see this is the posterior region which is showing larger amplitude of the delta, and also seen anteriorly with the lesser amplitude. This is the, in younger it will be more posterior, spreading anteriorly. And the HV has ended now because the child was able to do for 2 minutes. And after the HV has ended, you can see that there's not much of slow wave. Slow wave also terminates immediately after the HV stops. So what are the abnormal responses? You can see localized slowing. If you see a generalized slowing, it is normal. But if you see a localized slowing, you can think of a underlying abnormality. Or if there is a, in addition, instead of localized, even if it is lateralized, that means if it is seen only in one hemisphere, it can be an abnormality. Especially it happens after a delay. In a post HV scenario, you get a delayed response after a minute, then it could be abnormal. Even if it is generalized, if it happens after delay of a 1 minute in the post HV scenario, it is abnormal. And the well-known epileptiform patterns, if they are appearing during HV, they are all abnormal. The spike and wave discharges and all. So the HV response can sometimes have what's called a FIRDA, the frontal intermittent rhythmical delta activity, or the occipital intermittent delta activity, especially in children. The if they are happening spontaneously without HV or in the time when HV is not done, then it is indicative of an abnormality. But if they are present only after, only during the HV, it is normal. So occurrence of a FIRDA or a OIRDA in HV is normal. So this is a 10-year-old male where you have right-sided the patient has undergone a lesionectomy on the right posterior quadrant of the occipital region. This patient, you can see that there are some slow waves even at rest in the right posterior region. So as the patient does the HV, what happens? There is the persistence of this slow wave abnormality, which you can see the blue color, the backside posterior region, which is there. And now the HV is into the 20th second, and now we can see that some kind of a build-up of a slow wave activity is seen in the right posterior. And you can see that there is further build-up. Can you see the beautiful build-up of further slow wave activity in the right posterior region at 50 seconds? So this is a focal slowing in an abnormal brain of right posterior lesion. This is a focal slowing which is happening in an abnormal brain. So this is not normal and which is restricted to the right occipital region, which is on the, now you can see at 1 minute, you can see the slow wave which is persisting in the right posterior region. Now there is a 5-year-old girl with absent seizures. Now you can see this, as I told you the other day, the eye closure producing a beautiful alpha here. And the patient, the tapping is done by the patient. The patient hand, with her hand, she'll be tapping her thighs. The tapping is done, and this is the HV will start off, and the patient will stop the tapping, or if you can ask the patient to keep the hand extended, you can see that the hand will drop slowly. This is the occurrence or the onset of the beautiful 3 Hz spike and wave discharges on HV. So it's a beautiful discharge which evolves, and it stops at this time, and the patient immediately starts responding. This is the HV response in a typical childhood absence seizure. So it is the post HV status is this one. It's not showing any abnormalities. Now this is a 12-year-old male who has come with the history of syncope, but actually when we did the EEG, we found that there are this kind of spike and wave, 3 Hz spike and wave discharges. You can see the 3, you can count the one as 3 or 3.5 on HV. You can see the HV 40 seconds, you can see this kind of discharges. So what we thought as kind of a syncope was actually an absence seizure with a slow fall kind of situation which has happened in this patient. Now the other thing which I mentioned earlier was an unusually prolonged post HV slowing, high voltage slowing. And this buildup of slow waves after the end may be a diagnostic finding in children with moya disease. That's the reason why you should continue the post HV recording for at least 3 minutes. So this is a 40-year-old male with a right temporal lobe lesion. As you can see, even in the interictal record, the average record is a F5 T4 showing this spike. You can see these spikes in the right temporal T4. Now you can see on HV there is buildup of this slow wave activity in the right temporal region. So you can see that now at 20 seconds, the slow wave is increased in the right temporal. You can see the increased slow waves in the right temporal. This is the 1 hour 30 seconds of HV. You can see HV has stopped, and now this abnormality also is stopping within 30 seconds. So it should stop within 1 minute of post HV. Now, just an example to show the delayed HV response is you can see that after 2 minutes of HV, if this patient is showing this kind of a delta rebuilding, you can see the delta B rebuilding happening. This is indicative of an underlying vasospasm or a condition which is producing some kind of a resting ischemia. So predominantly it happens in Moya disease. So the contraindications of hyperventilation are severe cardiac disease, pulmonary disease, if there's an uncontrolled hypertension, when there's a raised ICP, or a recent vascular event like myocardial infarction, stroke, TIAs, sickle cell disease, what happens is that the patient might go into a crisis or patient might develop an infarction after the HV. And same thing, same issue can even happen with the Moya. So they might go into a infarction, a new stroke can appear if you do a HV in Moya. So now coming to the second one of activation procedure called photic stimulation, where we use the stroboscope or the photic stimulator, which delivers light at around 1 to 60 per second. And the lamp is held at the 30 centimeter in front of eyes. And the angle of visual field estimate is 13 degrees. And the signals are synchronous with each flash. So direction of fixation is towards a fixation point at the center of the lamp. So first we should do at 18 hertz. First stimulus is done at 18 hertz. Then you do the range is then tested from 1 to 30 or sometimes up to even 1 to 50 also. And each frequency, 5 seconds it is stimulated with the eyes closed, followed by 5 seconds of gap, and then 5 seconds with the eyes open. If the PPR is obtained, the photoproximal response is obtained, the photic stimulation should be stopped. Okay, otherwise you may get a seizure in front of you. You have to watch out for a seizure-like phenomenon. So the types of response you can get is a normal ones are the photic drive, or sometimes a visual evoked response, and the abnormal is the photoconvulsive response or the photoparoxysmal response. The artifacts can also happen with photic stimulation, which are known as the photoelectric artifacts or the photomyogenic artifacts. What is a photic drive? Photic drive is the EEG activity which is time locked to the photic stimulus. That is, what is the frequency you are giving in photic stimulation? You will get changes in the occipital region with similar frequency. So the occipital region is driven by this photic stimulation. So it's a physiological response. It can be either of the same frequency, or it can be a harmonic or subharmonic. For example, if you are driving at 3 hertz, you can get at 6 hertz or 9 hertz, which are harmonics of the basic frequency in which you are stimulating. For example, if you're stimulating at 12 hertz, you can get at 6 hertz. But usually this drive is symmetrical, but sometimes there can be amplitude asymmetry also. You can be present or absent normally. If the photic drive is not present, it doesn't mean that the patient is abnormal. So if the voltage is less or absent photic driving, there is no significance. If you get post, as I demonstrated the other day, the positive occipital sharp transients of sleep, which is seen in the drowsy individual in the posterior region, and the lambda waves, when you scan a complex pattern with the eyes open, the lambda waves, if the patient has these two, it will predict the presence of a prominent photic driving response in this patient. So those patients who are having post and lambda are likely to have a prominent photic drive. So this is a patient, you can see the eyes closed, the alpha coming. Yeah. So now this is one example where you can see that the photic stimulation, you can see the pink is going on, and here in the P4O2 and T6O2 as well as the T5O1, both posterior regions, you can see this, the activity which is happening at the same frequency as the photic. So this is the photic drive, or maybe this is harmonic or twice the frequency as this. can be harmonic, so you need to count it. So this is the photic drive. So this is the photic on 1 hertz. Now you can see 6 hertz photic stimulus. So in the 6 hertz photic stimulus, you get a 12 hertz photic drive. So that's a harmonic. Harmonic can be either multiples of 2 or 3 or divided by 2 or multiplied by 2 or 3. These are all or 4, that becomes harmonic. So this is stimulated at 6, but you get it at 12. This again is a photic drive. This is happening at harmonics. Now this is stimulated at 10 and you are getting at 10. So these are the same frequency as the stimulus. The photic you can see at 10, you can count this is 10 hertz and this is actually also 10. This is the photic drive. And now this is 12 and that's also 12. Photic is 12 and here this alpha like activity is also 12. This is actually a photic drive. And this is 14 and you can see this drive is also 14. So the photoparoxysmal response and photomyogenic responses. So photoparoxysmal response is something which you are interested in. It's 4 types are there, and the first grade is the one where it is seen the spikes are restricted to the occipital region, and second one where it is involving the parieto-occipital region with the spikes being seen there followed by a biphasic slow wave. The third grade is the one where you see the parieto-occipital spikes with the wave, but they are spreading to the frontal region, and the fourth grade is the one which is generalized spikes and waves or polyspikes and waves. The 4 types of or 4 grades of photoparoxysmal response. This is a 20-year-old female with epilepsy, and this is the photic stimulation, as you can see, producing a kind of a generalized kind of a frontally dominant, literally generalized spike and wave discharges. This is happening at 18 hertz. So you should remember that the normal patients or the people with the idiopathic generalized epilepsy, their photosensitivity is usually between the 10 to 30 hertz. It doesn't happen less than 10 and it also doesn't happen more than 30. So at 18 is the frequency which you should try first and see whether the patient is photosensitive. So that if you do at 18 and you get the response, then you should be careful in doing or stimulating the patient repetitively, because you might end up getting a seizure on table. That's the reason why if you start off with 18 to see any response and then go back to 1 to 30. So normal or the idiopathic generalized epilepsy or a JME patient will have photosensitivity, 30% of them, not everybody, photosensitivity between 10 to 30 hertz. So this is one patient showing a photosensitivity response at 18 hertz. So again, this is another patient showing a photosensitivity response at 10 hertz with eyes closed. And this eye closure is again a kind of a photosensitive response. And these patients can simply have these spikes on eye closure without photic stimulation also. And on eyes open, it becomes all right. So this is eyes closed and photic at 12 hertz. And this is at 14 hertz with the eyes closed. The eyes open, it is disappearing. You can see that this photic stimulation on eyes closed, you are getting these discharges, but when you open the eyes, the discharges are coming down. So the eyes closure or eye closure is again a kind of a photic response, or it's a visual stimuli. Eye closure is a kind of a visual stimuli equivalent to the photic stimulus. Again, it's another example of a response at 12 hertz, which happens only on eye closure and stops along with the stimulus. You can see this pink one, this stimulus stops here, and when the stimulus stops, this discharge also stops. And the persistence of the discharge beyond the stimulus, if it happens, then it's an indicator that the patient might develop a seizure. Or we can also say, because these things can be traits. What is a trait? An EEG trait means a normal person who is a relative of a patient with the JME can also have this EEG abnormality. But the person who has active seizures can or might have these discharges which might last beyond the stimulus. But for a person who is not having epilepsy or having only traits, there the abnormal photic response will stop with the stimulus. So as you can see here, this stimuli, with the stimuli, the abnormality stops and it doesn't kind of outrun the stimulus.
Hello,
So
yes.
hello.
Hello.
Am I audible?
Yes, Prabhakar Ray.
Arnold sir?
Audible, sir. Someone has unmuted. Continue.
Okay. So this is a 3-year-old female with the primary generalized epilepsy. So the HV has been started. Now there is a photic. This is the HV of this patient. Okay, there seems to be something happening in the left. We'll see further. This is photic at 18 hertz. Photic at 1 hertz. Now nothing was happening significantly, but when eyes closed, you can see some responses in this patient. Eye closure is the one which is bringing on this abnormality. So eye closure sensitivity. So this is very prominent and typical of G1's syndrome. Epilepsy in G1's syndrome. So you can see this eye closed. You can see this initially the alpha comes in, or kind of an alpha squeak, as you can see here, followed by the sunrise discharges. So these patients have what's called the sometimes eyelid myoclonia with absence syndrome, G1 syndrome. Now, 6-year-old girl, I can see the background is a bit low, and you can see what's happening here.
Before you go there.
All the participants, can you kindly switch off the audio? So this child, the photic stimulus is delivered at 1 hertz. So what is another important point which I like to tell you is people with progressive myoclonus epilepsy, they tend to have positive response, PPR response at lower frequency as well as higher frequency. So this is a child with the progressive myoclonus epilepsy. You can see that the photic is at 1 hertz. And when we give the photic at 1 hertz, you can see the discharges at 1 hertz. You can see the discharges here. And this child, the photic is at 3 hertz. Now you can see the photic is at 3 hertz. And you can see the discharge is also happening at 3 hertz. Then this photic is off, the discharges disappear. So again, the discharges, you can see the photic at 1 hertz. You can see as the discharges are happening with the photic at a lower frequency. This is at 2 hertz. Then you'll get again discharges happening at 2 hertz also. So people with that's one way of the diagnosing the progressive myoclonus epilepsies is the photosensitivity at lower frequency of stimulus and even at higher frequency like 35-40 hertz also. In addition to the giant SSEP, which all of us will know that they are diagnostic of this progressive myoclonus encephalopathy. So photoparoxysmal response is commonly seen in juvenile myoclonic epilepsy, childhood absence, juvenile absence, and sometimes in benign myoclonic epilepsy of infancy. An epilepsy with the myoclonic astatic seizures or the Doucet syndrome, the Dravet syndrome. An epilepsy, the GTCS on awakening, then the occipital epilepsies can show this photoparoxysmal response. And as I mentioned, if the PPR is positive at a slower rate like 3 per second, it is indicative of the Laffer body disease. That's a progressive myoclonus encephalopathies and epilepsies. The Laffer body, the MERV, the MELAS, neuronal steroid lipofuscinosis, and Dravet. Even in Dravet, you can get the slow stimulus-induced photic responses. So this is something which you can identify that the photic is given at 4 hertz. You can see that the frontalis muscle is twitching at 4 hertz, mainly on the left side. So it's a photoelectric artifact. This is a and the photomyogenic artifact. So if the electrode is moving at the same rate as the photic stimuli, photoelectric artifacts, you can see at 4 hertz, the electrode is moving at 4 hertz. This is photomyogenic, which is again more seen with the left side frontalis muscle. This is going at the same rate as the photic stimulus. Now, there is another thing which I want to emphasize today. It's a pattern activated photoparoxysmal response. This is something with all our postgraduates should start doing in our day-to-day practice. Photoparoxysmal response, you try to evoke not only by photic stimulation, but also by pattern activation. One thing which I told you yesterday is like the glossokinetic thing which you should look, asking the patient to say la 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 and look for the response, which we should start doing, everybody. Similarly, the pattern activated photoparoxysmal response, because in some individuals this is likely to evoke a pattern than the photic stimulation.
He 14th of this month.
The likelihood of patients with the diffuse PPR having response to stationary pattern means between 5% to 22%.
तो जरा कंफ्यूजन है, फाइट है नहीं चेंज गवर्नमेंट अलाउ नहीं कर रहे हैं.
My God, this guy is a disturbance for everybody.
उसके बारे में तो पूछना था काउंटर को कि क्या है
I don't know who. The most effective activating patterns for either stroboscopic pattern stimulation or stationary pattern being consists of vertical parallel lines with high contrast. So I will just show you the patterns which you can use. And typical absence is the most commonly activated seizure type among individuals is self-induced photosensitivity pattern sensitive epilepsy. So the goal of identifying pattern sensitivity is the removal of certain patterns from the patient's environment. For example, if you look for these patterns, these are 5 patterns are there. You have to make a board, some kind of a checker kind of board with these kind of patterns. And when you move the patterns in front of the patient's eye, you can get the discharges. And those patients who are getting these patterns should avoid watching these kind of movies with rapidly oscillating movies or games, or the games will have this chessboard kind of pattern. So in those patients, these kind of patterns will be provoking the seizures. So when you try to do this pattern stimuli in these children or these patients, you can get this abnormality. So the visual stimulation should not stop with photic stimulation. All PG should now include the pattern stimulus. So in a cardboard, you should have these patterns, and these patterns should be moved in front of the patient's eyes to see whether they are eliciting any kind of abnormality. This is a 14-year-old female. Now the eyes closed, you can see the occurrence of generalized spikes. And with photic, you can see some abnormalities happening. And with the pattern also. Now this is the EEG picture of the patient being shown a pattern. And with pattern also, the patient is showing a generalized abnormality. So this patient has got a pattern sensitivity. Other thing which I want to emphasize is the scotosensitivity discharges or fixation of sensitivity. This is a response to eye closure, and it disappears completely or attenuate on eye opening, and when it will return promptly immediately on closing the eyes. So this is one example of the fixation of sensitivity commonly seen in the Panayotopoulos syndrome, the idiopathic childhood occipital lobe epilepsy. This is the thing, spikes which appear. You can see this immediately on the closure of eyes, or more importantly, more than eye closure, is the fixation of, even with your eyes open, if you are not able to fix, for example, special goggles if you wear, where you are not able to fix on any object, you can even be with eyes open. But the fixation is being prevented. The macular fixation is prevented. That is the most important stimuli for this. You can see immediately the spikes come in. The moment the eyes open or you try to fix something, it will disappear. This is the place where it disappears. And immediately, if you close, immediately it appears. This is called scotosensitivity. So this is the eye closed sensitivity. The other one is eye closure sensitivity. Eye closure is on closing the eyes, the discharges usually occur within 2 or 3 seconds. Eye closed, the discharges occur immediately, and it will persist throughout the record of eye, the fixation being off or the eyes being closed. Whereas the eye closure sensitivity is a photosensitivity, it will appear within 2 to 3 seconds and it may not last throughout, it will last only for a short period of time of eye closure. Now, having discussed the hyperventilation and photic stimulation, the activation during sleep, it's a very, very important procedure. So, where both generalized and focal IDs can be activated, but we should understand that in generalized epilepsy syndromes, idiopathic generalized epilepsies, they are predominantly activated during awake state. But the focal epilepsies are the ones which are predominantly activated during sleep. So in as many as 1/3 of patients with complex partial seizures, they may not have the spikes during awake state, but it will appear only during sleep. So if you report a EEG as normal of somebody with a focal epilepsy without doing a sleep EEG, you are missing in 1/3 of the patients. Nearly all patients with IEDs during daytime nap recording have their first discharge within 15 to 30 minutes of sleep onset. Thus, an OPEG in patients with suspected seizures should always include sleep. It can even be some 15 to 20 minutes. Now, the pedicloral, chloral hydrate is the one which can be used without producing any EEG abnormalities by itself. The temporal lobe spikes will become multifocal or more diffuse, or you get a lot of abnormalities in temporal lobe epilepsy, which is not seen in the awake state. So there are epileptic syndromes with spikes which are activated by sleep. One is electrographic status in sleep. Benign onset epilepsy. The benign epilepsies all get activated in sleep. Lennox-Gastaut syndrome get activated in sleep. And the frontal lobe epilepsy, which includes autosomal dominant nocturnal frontal lobe epilepsy. These are the conditions where you're going to get the spikes predominantly or exclusively in sleep. This is a 7-year-old patient with, I think, Landau-Kleffner syndrome with this kind of immediately on sleeping. You can see the tremendous activation of spikes. You can see the FP1 and F7, tremendous activation of spikes. Whereas the awake will not show any spikes. And the sleep will immediately bring on plenty of spikes. It's Lennox-Gastaut syndrome again, another scenario where the sleep induces a lot of abnormalities, which is similar to the something like continuous spike and wave activity during sleep. LGS in a 5-year-old male, and the awake may not show. The awake may be very deceptive, and it will not show any abnormalities which is present in the patient. A benign Rolandic epilepsy, you can see the left centroparietal or centrotemporal spikes, very frequent in the sleep. So this is one situation where as the sleep produces plenty of spikes, the condition becomes more and more benign. That is, you see a lot of spikes in the EEG, but we can counsel the parents that it's going to be a benign scenario. So this is a benign Rolandic epilepsy. This is another example of a patient with the left temporal lobe epilepsy associated with the MTS, visitor musculosis. You can see the left temporal spikes here, but what happens in the during sleep, you get increased number of spikes as well as 30 to 30% of them will also have spikes on the contralateral medial temporal region, as you can see here. Yeah, these are the spikes which are activated by sleep. So sleep activates the focal epilepsies, or the focal epilepsies in particular, as I mentioned, symptomatic focal epilepsies as well as the benign focal epilepsies. In both the conditions, you get increased activity in sleep as well as symptomatic generalized epilepsies like LGS, where you get tremendous activation during sleep. So imagine a situation when you report an EEG without a proper sleep EEG, you are most of the times incomplete or inaccurate. A sleep EEG is an extremely important activation procedure and a necessity in your day-to-day EEG recording. So summing it up, because I already reached 50 minutes, summing it up, it is the hyperventilation and photic stimulation, which are the common activation procedures. In addition, the eye closure can become an activation procedure, and also sleep deprivation and the normal sleep. They are the regular common activation procedures during sleep. And in addition, based on the clinical scenarios, I am not showing those videos of your EEGs of eating epilepsy, reading epilepsy, all those reflex epilepsy. These are all activation procedures where you use them to bring in the intellectual epileptiform abnormalities, because we have only a short period of time to look into the EEG and make a diagnosis. So during this short period of time, if you want to get the abnormalities, it may not be possible. So we need to use these activation procedures to bring out the abnormalities. So much for uh, the activation procedures. And I thank you all for the patient listening, and thank you, the neurosciences department of SRM, for giving me this opportunity. Back to Arman, sir.
Thank you, Dr. Rajesh. It was a very nice lecture. Hope everybody enjoyed that. Anybody has got any questions, they can ask now, either through chat or you can unmute yourself and ask. Anybody has got a question, you can unmute and ask. If there are no questions, we can go on to Dr. Malcolm's lecture. Any questions? Dr. Rajesh, it was very, very nice presentation. I hope everybody has no doubts, I think. That's why they are not asking any questions.
Okay, sir. Thank you so much, sir. Thank you.
Thank you. Very well done. Thank you very much. I now request, and I think there is a question coming. Can you see the chat box? In cardio electrographic status epilepticus, what is the abnormal EEG? We'll see in during HVS and the activation procedure. Mr. Balaji Nagarajan has asked. Sir, can you see and give an answer for that, Dr. Rajesh?
What is the question, sir?
Sir, in electrographic status epilepticus, what is the abnormal EEG seen during HVS and activation procedure? HV and activation procedures, I think.
When the electrographic status is there, then there's no need for activation because they're already getting the abnormality there. So that is already we are doing the activation to get the abnormality. So electrographic status means the EEG will show that the seizure is going on. So there is no need for activation in those situations.
Okay, Dr. Rajesh, thank you. I think he would have.
Hi, Malcolm.
Hi, sir. Nice to meet you, sir. Very nice lecture.
Bye. Oh, you were there. Okay. I'm leaving Malcolm because of some cases are there.
Sure, sir.
Okay.
Thank you.
Bye, sir. Arun, sir. Bye. Thank you.
Bye, sir. Well done, sir. Thank you.
Sir, very good afternoon.
Yeah. Welcome, Malcolm. You can start sharing your screen.
Thank you very much, sir, for the opportunity. Nice to be with you. And
we can start, Malcolm. You can share
yes,
your.
Yes.
Make it full screen. Make it slide show, Malcolm. Make it slide show.
Yes, sir. Is it okay? I'm.
Yeah. Nice.
Visible, sir?
Yes, very nice. I will unmute. All the others also, please mute so that there will not be a disturbance, audio disturbance, please.
At the outset, a very good afternoon to all. I thank Professor Arvind, sir, for giving me this opportunity to be with you through Zoom to share on benign epileptiform variants. Waveforms that have an epileptiform appearance but are not epileptogenic are considered as benign epileptiform variants. Sir, can I continue, sir? Hello? They may be sharp contoured. They may occur singly or in rhythmic bursts or in trends.
Just a minute.
Audible, sir?
You are audible, but someone is has unmuted. Please all mute your audios, please.
Shall I continue, sir?
Yeah, you continue.
The benign epileptiform variants occur largely during drowsiness and light sleep. They are seldom noted during wakefulness or deep sleep. So this is the trademark differentiating point between an intractable epileptiform discharge and a benign epileptiform variant. So the careful recording of the first transition from wakefulness to sleep is extremely important to identify these benign epileptiform variants. And for better delineation, we have to always use the referential montage. There are 6 different variants, about which you'll be seeing in depth subsequently. And they are broadly classified as sharp contoured variants and variants that occur in bursts or trails. Sharp contoured single spike variants, I would rather say. The sharp contoured variants are benign sporadic sleep spikes and the wicked waves. Those that occur in trains are 14 and 6 hertz. The phantom spikes, which are otherwise called as the 6 hertz spike and waves. The rhythmic mid-temporal theta bursts of drowsiness, and the Shreda. This is an article published by my chief, Professor Radhakrishnan sir, from Chitrathirunal, wherein they try to analyze, say, in around 1,800 patients, how many percentage of these patients in whom EEG is done showed benign epileptiform variant. And they found that the benign sporadic sleep spike is the commonest one. It is seen in around 8% of the subjects. The next common one is the 14 and 6 hertz, and the next common is the 6 hertz. That's namely the phantom spikes. So in total, they found that around 18% of these patients had benign epileptiform variants. Now, why benign epileptiform variants becomes very important in identification is many times these benign epileptiform variants are identified as focal epileptiform abnormalities. And when they are identified as focal epileptiform abnormalities, it may lead to initiation of anti-epileptic drugs in such patients. And in some patients, a genuine withdrawal may not be possible because of the identification of benign epileptiform variants as intractable epileptiform discharges. So I'll go ahead with my first variant, namely the benign sporadic sleep spikes. It is the most frequently encountered,
Malcolm, you are not audible.
Not audible, sir.
Ah.
Now, sir?
Yes, now audible. Now audible.
It is seen as single monophasic or diphasic spikes. It has an abrupt ascending limb and a steep descending limb. May have a single aftercoming slow wave component or an aftercoming dip in the background, and the slow wave is never prominent. It occurs in singles. It never occurs in trains. The morphology may vary with the montage used. The highest amplitude is seen with the long interelectrode distances. Occurs as a unilateral waveform. Bilateral representation is common, but commonly independent, or may be seen as a reflection from the other side. I will discuss all these points in the subsequent EEGs. So this is a double banana montage where you it's a double banana montage with a normal background activity in an awake state, the patient having a blink response. This is the next subsequent slide, which is a average montage, and as you see, a very small spike and an aftercoming slow. But the most important point that you see is this does not disturb the background. So almost the background is as such is going, and just a small spike, which is low in amplitude and very short duration, is seen just jutting out to the right frontotemporal regions. And this is another idea of a double banana montage. We see a similar spike, a very small spike, but instead of an aftercoming slow wave, you see a dip. But the points that I want you to recognize are, it comes in singles. It doesn't disturb the background. and as the alpha is getting dropped out, it appears. And if you follow it up in sleep, it will disappear. I'm not going into this. Okay. This is this is an average montage, and this also shows a very small, very small amplitude spike followed by a very small upcoming slow wave. But it is seen bilateral. But here it is seen more as a reflection on the of the left temporal on the right temporal. Now, why I brought this slide is just for us.
Not audible. Malcolm? Hello? Malcolm, not audible. Audio not coming, Malcolm.
Sir, am I audible?
Yeah, now audible, now audible.
Sorry, sir, there is some internet issues, I think.
Yeah, problem.
Sir, why I brought this particular slide is for to understand how close it could be to differentiating between a benign sporadic sleep spike from an interictal epileptiform discharges. Now, this spike which I am showing you here, or a transient I am showing you here, also mimics something like a benign sporadic sleep spike. But let's analyze and see how different it is from a BSSS. Here, if you see, there is a clear disturbance of the background. The background is going on, but once the spike and wave appears, there seems to be a background disturbance. There is a field. There's a clear aftercoming slow wave. Now, I go back to the previous slide, and I'm asking you to see the same spike here. You see how tiny it is. It is also a spike, but there is no disturbance of the background whatsoever. If you follow this into deeper stages of sleep, actually, there will be more and more number of discharges coming in case of a focal epileptiform abnormality, rather than seen in a BSSS, where it will disappear during sleep. And here also you see another true IED, where it is minute, small, but you can see that the moment the spike appears, it disturbs the background. It disturbs completely the background here. And the next point is, whenever you see these kind of small spikes and they occur in trains, they are most likely true spikes rather than benign sporadic spikes. Now, to summarize the point, I will put these four are the main differentiating points. The BSSS does not distort the background, whereas the spike distorts the background. In a BSSS, it may not be associated with aftercoming slow waves, but generally a spike is associated with an aftercoming rhythmic slow wave activity. The BSS does not occur in trains, while the spike occurs in trains. The BSSs diminish or disappear with slow wave sleep. The spike increases with the deeper levels of slow wave sleep. And it is commonly
Malcolm? Not audible, Malcolm.
the frequency is 6 to 11 hertz. The amplitude is around 60 to 200 microvolts, and it lasts for around 0.5 to 1 second.
Share your screen, Malcolm. Your screen is not coming.
Sir, it was visible, sir. Suddenly,
Now even now the screen is not coming. Only your video is coming.
Just a moment, sir.
You see, share the screen.
I'll do it, sir. I'll do it, sir.
Right. Yeah, it's right.
Just a moment, sir.
Right. Yeah. Okay. Welcome.
So I'll go ahead. Shall I go ahead, sir?
Previous.
No. So the
Previous
wickets.
not audible. Yeah.
Am I audible, sir?
Yes. Now audible. Now audible.
The wicket spikes were first described by Iyer and Label in 1977. They are either seen as monomorphic archiform or single spike, or a single spike. They look like Greek mu or wicket. The frequency is generally 6 to 11 hertz, and the amplitude is around 60 to 200 microvolt, and it generally lasts for around 0.5 to 1 second. As discussed for BSSS, it is mainly seen in drowsiness and light sleep. It may be present during wakeful state, but masked by background rhythms. And it is seen predominantly over the temporal chain. It can occur bilaterally and independently over the two temporal regions, and it is likely to represent the fragments of so-called temporal alpha activity. And here you see a double banana montage, and you see some sharp transients in T3 and T5, and they look too sharp to look like a spike. But this spikiform region, once again, does not distort the background. I will show you some subsequent spike to differentiate between a wicket spike versus a true IED. And you see another it's an average montage, and you see FP1, F7, and T1, a sharp transient, or rather a series of sharp transients which do not disturb the background. And the patient is shifting into stage 1 to 2 of sleep with vortex wave and spindles. But here in this slide, what I'm trying to show you is trying to contrast between the first slide I showed. The first slide I showed, there is no disturbance of the background whatsoever. But in here, you can see that this spike, once the spike comes in and there is an aftercoming slow wave, there is a clear distortion of background. This is a true temporal spike, whereas the former is a wicket spike. And as I had told, as a rule of thumb, for all benign epileptiform variants, the benign epileptiform variants, as they go into deeper stages of sleep, they disappear. While a temporal spike, as it goes into the deeper stages of sleep, the frequency and the frequency increases quite considerably. So to register the crucial points of difference between a wicket spike and a temporal spike would be: a wicket, there is no aftercoming slow wave, while in a spike, there is an aftercoming slow wave. The wicket usually does not disturb the background, while the spike stands out of the background. The wicket disappears with sleep. The true spike becomes more pronounced in deeper stages of sleep. And the common age group in which the seen is between 20 and 50 years. And the percentage is around 0.96%. Now coming to the next entity, which is the 14 and 6 hertz spikes. They are called as the tinoids, and they are 14 and 6 hertz positive bursts. They were originally described by Gibbs in 1951. They are a rhythmic trains of arc-shaped waveforms. They have alternating positive spiky component and a negative smooth rounded waveform. And they may resemble a sleep spindle with a sharp positive phase. They are seen in brief paroxysms, usually less than 1 second. The faster frequency is more prevalent at 14 hertz, and the 6 hertz can occur in association or independently. I will be showing the EEG subsequently. The best displayed on referential montage the Eyer. The maximum amplitude is seen in the posterior temporal regions. They are often asynchronous and independent, but preferentially involve one side. So here you see a CZ montage, and in the CZ montage, you see here more in the posterior chain, a kind of a comb-like appearance. It's like a comb. You have a positive spike and an archiform negativity. And this, if you count, will be around 14 hertz. So this is the classic 14 hertz spike. Sorry, 14 hertz wave. And this is a similar example which is seen of a 14 hertz wave, but it is more pronounced in the posterior segment, more pronounced during the initial stage 1 of sleep, stage 1 to 2 of sleep. A similar picture in an A1 and A2 montage, just for the A1 and A2 I've shown this, which shows another 14 hertz and a 6 hertz. This is the classic 14 and this is the classic 6 hertz. Now, which do we differentiate this from is the spindle. The spindle is what I'm showing here. Now I go back here and you look at this, not even this, you look at this and you look at this waveform. If you look at the waveforms, they may almost look quite similar to each other, except that there is a much sharper negativity. But the classic point of difference between a sleep spindle versus a 14 and 6 hertz is the 14 and 6 hertz is more posterior, whereas the spindle appears in the parasagittal chains and in the midline chain. So here you see predominantly in the midline as well as in the parasagittal. So the crucial points of difference between a 14 and 6 and a sleep spindle are 14 and 6 is archiform, while spindle, as the name implies, it's spindle-like. It is the 14 and 6 has got a sharp positive phase, whereas the spindle has none. The 14 and 6 appears more in the posterior temporal or occipital regions, while the sleep spindle happens in the central or parasagittal chains. The prevalence is it begins to appear in children of 3 to 4 years of age, maximum in adolescence. It progressively decreases with increasing age, and the age group which it is commonly seen is between 6 and 31 years, and it's commonly seen across both genders. Another important benign epileptiform variant that we are going to discuss today is the 6 hertz spike and wave discharge. This is commonly called as the phantom spike and wave. The spike is followed by a slow wave, but many times the spike will be too small. It is like a phantom. And the slow wave following it is quite prominent. And why it is called as phantom, as I told you, the spike may be difficult to see and it appears and disappears like a phantom. The range is 5 to 7 hertz. The brief hertz could last for 1 to 2 seconds. It rarely persists for 3 to 4 seconds. It's usually bilateral, synchronous, and diffuse. Can be asymmetric, anterior or posterior head region dominant as per the gender. The Hughes classified it as WAM, which is wake. It is seen more in early wakefulness. It is high amplitude. It is anterior, dominant, and it is seen in men. The fold, because it is seen in the females, it is seen in occipital predominant. It is of a low amplitude and seen more during the drowsy phase. As all benign epileptiform variants, it appears during relaxed wakefulness and drowsiness, and it may disappears during the deeper stages of sleep. And the prevalence is it happens in adolescents and young adults around 2.5%, and the common age group that it is seen is between 6 and 31 years. Now this is a classic phantom spike. Here you see a very small, an average montage, a very small and sharp transient, followed by a slow wave. But many times this small and sharp transient would be submerged within the slow wave. Now, if you look at it, it more or less looks like a probable frontal spike, but it is a classic benign epileptiform variant, and if you watch it through sleep, this will disappear, whereas a frontal spike would get exaggerated. This is a similar average montage, which is showing a very small sharp transient followed by after coming slow wave. The same, I'm not repeating here. Whereas this is more of a posterior dominant phantom spike, where it is seen as a small spike and after coming slow wave. Now this can sometimes be very tricky, and we would rather be, sometimes name it as an occipital spike. But the mantra to differentiate a benign epileptiform variant once again from an occipital spike is, or a phantom spike is, this disappears during the deeper stages of sleep. Now, the fifth benign epileptiform variant that I would like to talk on is the rhythmic mid-temporal theta of drowsiness, which is named as a psychomotor variant by Gibbs and Gibbs in 1952. It happens in bursts or serial trains of rhythmic theta waves, and it is characterized by long paroxysms of rhythmic activity. With regards to the morphology, it is flat-topped, sharp-contoured, or has got a notched appearance. The notching is due to the superimposition of faster frequencies or due to the harmonics of the resting background frequency. The distribution is maximally seen in mid-temporal electrodes, often spreads to the parasagittal regions. It can be bilateral or independent, and can be bilateral but independent of the two hemispheres with a shifting preference, and it appears during relaxed wakefulness and drowsiness. Now, the point why this RMTD is very important is it many times mimics a temporal ictal rhythm. I will be showing the subsequent EEGs. Here you see a classic notched appearance of a train of discharges, which is seen in the temporal region. But the most important point that I would like you to note here is there is no dynamicity in the progression. It runs smoothly, and there is no changing frequencies. You see this 1, 2, 3, 4, 5, 6, 7. Same 1, 2, 3, 4, 5, 6, 7. Almost the same. There is no different. There will be no change in the frequency or in the morphology in its evolution. But this I am showing for us to understand the classical ictal theta rhythm, which is happening over the temporal chain. This is the right temporal chain, and you see it starts quite slowly, the rhythm, and then it picks up a theta rhythm. And as you see, this theta rhythm starts evolving both in morphology as well as in frequency. And at one point, it gushes up. What was seen as 6 to 7 hertz would rather end up somewhere around 9 to 10 hertz and further evolves as a spike wave pattern. So this is a classic ictal temporal rhythm, whereas this is even more clearer. This is a classic RMTD. So this is the point of difference. Here you have to differentiate the RMTD from an electrographic or a clinical seizure. In RMTD, there is no evolution over time, whereas electrographic seizure constantly evolves over time as the seizure progresses. There is both polymorphicity as well as dynamicity. In RMTD, the patient is arousable and alert, whereas in an electrographic seizure, the patient is not fully alert and arousable. The next or the last one that I would like to talk about, which is quite uncommon, is the subclinical rhythmic electroencephalographic discharge of adults. It is uncommon. It is seen in older age people, more than 40, 50 years of age, can occur at rest and during drowsiness, and HB may precipitate sometimes as STRADA. The STRADA is a transient EEG pattern with mixed frequency components in delta and theta frequency. It evolves into a rhythmic pattern of sharp contoured waves, lasts for around 20 seconds to a minute. It's widely distributed, but maximum on the parietal or on the posterior temporal head regions. It's got an abrupt onset or a stuttering onset with sharp waves of increasing frequency and evolving into a sinusoidal pattern. So here you see a bipolar montage. The patient is awake, having blink responses, and as you see a kind of a theta rhythm it suddenly evolves as a burst, or it starts evolving, keeps evolving without much change in dynamicity, and it can have a sudden abrupt upset. Now, the point of differentiation would be between a strata and an RMTT rather than between a strata and a two epileptiform discharge. The strata is more posterior, can be polymorphic and dynamic with a theta frequency, and it is so far described in adults more than 50 years. So with this, I would like to conclude this talk, and I would say the last 3 points. Many times, identification of benign epileptiform variants as interictal epileptiform discharge leads to an erroneous diagnosis of epilepsy. It is important to apply strict criteria to identify benign epileptiform variants during the reading. And differentiation between spikes and ictal rhythms and VEVs is extremely essential. As a rule of thumb, I will always say the crucial area it is seen is between wakefulness to sleep transition. And if you are really confused whether it's a benign epileptiform variant or a true spike, allow the sleep to continue. And that is the best time to differentiate between a benign epileptiform variant versus a true spike. And if you take home this message, that I would be very much pleased. And thank you very much for the opportunity, sir.
Thank you very much, Malcolm. It was a very lucid and interesting presentation.
Thank you, sir. Thank you.
And anybody has got any questions, you can ask or you can send it through chat. I will read out for you. Anyone? Everyone is thankful only, Malcolm. Nobody is asking you questions. What is the commonest benign variant you come across?
BSS, sir. BSS.
If there is no other question, I think we can conclude and we will meet on 9th afternoon. Sorry, 12th afternoon.
Yes.
Malcolm is going to come. Isn't it, Malcolm?
Yes, yes, yes.
Yeah.
Focal
Focal epileptiform abnormality.
Thank you once again for the wonderful opportunity. Thanks to be with you all, sir. Thanks to your entire team. Thank you.
Thank you, Malcolm. Thank you all for joining. Thank you very much. Cut பண்ணிட்டாங்களா?